Valiathan in this occasion of National Science Day Week celebration at MCNS. As is well known, Professor Bhagiratha is a world-renowned cardiac surgeon. Let me briefly introduce Professor Bhagiratha a little bit more. Professor Bhagiratha's medical education took place at the Medical College, Trivandrum, University of Kerala, where he obtained his MBBS degree. He later went to the University of Liverpool, England, as a surgical trainee and received his fellowship from the Royal College of Surgeons of Edinburgh, England, in 1960, and the master's degree in surgery from the University of Liverpool. After a brief stint as a faculty member at the Postgraduate Institute of Medical Education and Research, Chandigarh, he underwent further training in cardiac surgery at the Johns Hopkins, George Washington, and Georgetown University Hospitals, United States. He has served on the faculty of the Georgetown University Hospital, Postgraduate Institute of Medical Education and Research, Indian Institute of Technology, Madras, and as a director of Sri Chitra Institute of Medical Sciences and Technology. Then, importantly for us, Professor Valiathan became the founding Vice Chancellor of Manipal Academy of Higher Education. He also served as National Research Professor of the Government of India. He has awarded many honorary awards. So to name a few, the second highest civilian award in India, the Padma Vibhushan in 2005 for his contributions to health technology in India. He was made a Chevalier in the Ordre de Palme Academics. Sorry, I can't pronounce French very well. An honor bestowed by the French government in 1999. He received the Dr. Samuel P. Asper International Award from the Johns Hopkins University Medical School in 2009 for his contributions to international medical education. Today, he will be talking about the indigenous development of Chitra TTK valves, prosthetic mechanical valves, which provided access to economically low-income patients to get the prosthetic valves replaced and hence saved their life. So let us hear from Professor Valiathan himself about the journey. So Professor Valiathan had agreed to be here today earlier to deliver this talk and interact with the audience. But unexpectedly, there was an important meeting called by the Chief Minister of Kerala. So he couldn't come here today. So his talk is recorded, which we will be playing here.
It's a great joy for me to join you here during this National Science Week, which is leading up to the National Science Day, February 28th, when Sir C.V. Raman discovered the Raman effect. He continues to remain a beacon for all of us. Even 50 years after he passed away, he continues to shine and serve as a source of inspiration for all of us. Our title today, the Sri Chitra TTK valve, and the development of that valve in India would be of great interest to Sir C.V. Raman. Because among C.V. Raman's interests, one of them was the development of instruments in India. In his great work in Calcutta on Raman effect, the spectroscope used was built in Calcutta by skilled workmen working under his direction. He used to take great pride in this. So here is again, we have followed that model a complex device like a heart valve being developed entirely in India. So I think he would have been very pleased with this subject. But one-way check valves have been used in engineering for many years. There is nothing new in that. A check valve ensures that fluid flows only in one direction. That's what it does. And Chitra valve is also exactly that. It has three parts, and one is that ring, a plastic fabric ring all around the valve. That is one part of the valve. The second is the metallic part. That is the cage of the valve or the framework. It is called housing. It has different names, but that's the housing made of metal or alloys. And the third part is the disc, which is made of plastic in this case, but it can be made of pyrolytic carbon. It can be a ball instead of a disc. So essentially what it does is an occluder. It occludes that orifice. When it comes, nothing can go through that. So there are three parts in the valve. One is the ring through which the surgeon puts stitches to fix it in position in the heart. Second is the housing or the cage made of metal. And third is the occluder, which can be a ball, which can be a disc. In our case, we are using a disc. These are the simple structure of the valve. But when you come to applying it in a human patient, the valve that you want to replace is very highly complex. Now here is a picture of the heart. The two upper chambers have been removed in this case. So you are looking into the pumping chambers. There are four valves. That is one valve. These two valves, which I pointed out now, these are the outflow valves. When the heart pumps, blood comes out through these two valves. One, the blood goes to the lung for purification. The other distributes blood throughout the body. What's the pulmonary valve, the aortic valve? These are the two valves which you see in front. And these are leaflets, three leaflets. That is how the structure is. But the two other valves are entirely different, as you can see. Now here is a valve. Here is another. There are two valves here which are different from the other two valves which you have seen. Now these two valves, they are receiving blood into the heart. Because heart keeps on pumping, that's the only function it does. Blood flows out through the two outlet valves which you saw in the beginning. One carries blood to the lung, the other carries blood throughout the body, pulmonary and aortic valves. But as it pumps out, blood has to come in to fill the heart. That happens through these two valves. Venous blood comes to the heart through the valve on the right-hand side. This is the valve through which the venous blood from all over the body comes to the heart. And the other one, here, the purified blood coming to the heart left atrium from the lung, that fills this chamber. So heart functions in cycles. A cycle, the pumping takes 1/3 the time. One cycle is 1/3 the time is taken by contraction of the heart, which is called systole. And 2/3 the time is taken to fill it. That is diastole. That is how the heart functions. And these valves are, the extraordinary thing is, they function under very difficult conditions because they are always submerged in blood. And secondly, with very small changes of pressure, they should be ready to open and close. The tolerances are very small. And most importantly, they open and close 100,000 times a day, 100,000 times a day, which means 36 million times a year. And 10 years durability, which the international standards require, is 360 million times. And this happens from the childbirth, even in utero, the heart beats, and it goes on as long as the man lives. So you can see the enormous challenge the heart valves face, how they function, and how the development is extremely complex. Now this is you have seen the heart in diastole when it is receiving blood. This is when it is systole, it is contracting, pumping. You can see the outflow valves are open at that time, whereas the other two valves are closed. And this has to function perfectly. If there is any failure in closure or failure in opening, then the patient becomes very sick. And sometimes the sickness may be such it is not repairable, and you have got to replace that valve. That is where we are in this subject. So when we see patients with very severe symptoms, either these valves are not closing properly, so that there are leaks, or they are not opening properly, so that the output is blocked. That is where the problem comes. Now, when we decide, my problem was when I reached Trivandrum in 1974 in a new institute. We had plenty of patients with valvular heart disease. These are relatively young, in their late 20s or 30s. Unlike in Western countries, the average age is around 50. So we are young patients here, and large number of women. This rheumatic heart disease is more common in women. So when we started doing open heart surgery, I was trained to be a cardiac surgeon, so I knew how to do it. We had plenty of patients, but the problem was the valves. Valves have to be imported, very high cost, 8,000 rupees in those days, and our patients were poor patients. It's a government institute. Government wanted all this done free for them. So we had very quickly a problem of waiting list of patients. 100 patients, 200 patients in a matter of 2 years. Now it's impossible when you see these patients who are sick, they cannot breathe, and you tell them you come after 2 years, your turn will come. It's the most heartless things to do. We couldn't do that. So that is when we decided. It was like I was trained as to drive. I had a driving license. But I come here and I'm told you build the car. It is almost like that. So I had a colleague, young colleague, Bhuvaneshwar, who was my student in Madras IIT. I was there as a visiting professor for a year. He was a very bright student there. So I asked him whether he would come and join me here to develop a heart valve. It's a rash thing to do, but anyway, he came. And we were the one who started this whole project. Most people did not take this seriously at all. And what you see at the bottom of this slide, these are the papers we published at that time. Whatever we were doing, we were careful to document and publish. So 1982, we had dreamt of starting the valve development. Now, if you decide to develop a valve, you have to go through certain steps. First of all, you have to decide what is the type of valve that you want to make. Is it a disc valve? Is it a ball valve? Or you want to make biological valves, like take a porcine, a pig valve, process it and use it, bioprosthetic valves. So this decision you have to make. Often there is an impression in India, especially foreign people, they will say, why can't you take porcine valves and use it? Why do you have to make mechanical valves with so many problems? This is a profound misunderstanding, because in Kerala at that time, the the valve should be harvested from licensed abattoirs under very clean conditions. And when you take these porcine valves from the pigs which are slaughtered, almost 80% are rejected in Western countries because they have either some abnormality or some disease. Various reasons they are discarded. Only 20% are acceptable. And it should be done very quickly because abattoirs have contracts with airports. They are put in a double pouch, shipped to California, the receiving station. So it reaches the lab in frozen state in less than 24 hours. And they are processing it is a chemical processing to remove all antigenicity and so on. They have to be mounted on a bioprosthetic frame. Now this all takes a very high level of technology. And that's why the bioprosthetic valves are much more expensive in Western countries. Here, we don't have such licensed laboratories. There was only one in Kerala at that time, when we started this work. And that they were only slaughtering 200 pigs. There is a lot of unlicensed slaughter going on that we cannot use for this. So it didn't take us long to realize that it's not a viable option for us. And we decided we'll take a low profile valve, disc valve, because our patients are younger. That's how we chose that. Then the materials we use, metals are used, plastics are used, all these must be characterized. It is not just going to the market and buying. And here, the ASTM, American Society for Testing Materials, they have detailed standards prescribed for all these materials, alloys, plastics, everything. Now we generally go by that. So the test is done. Many of the manufacturers actually will give ASTM certificate, they comply. So only such materials can be used in this. Toxicology tests are not difficult. These are again prescribed internationally. Make extracts from that, if it is a plastic, and see whether in small animals like guinea pigs they are toxic. There are certain prescribed tests which we have to do. So make sure that there is no toxicity involved in this. These are essential. Not too much of a challenge. Fabrication of a prototype, that is where the problem begins. If you have decided, as we did, for a prosthetic heart valve of the disc variety, then you have got to fabricate the housing, the cage, made of metal or alloy. You have to make an occluder, which in our case is a disc. That has to be fabricated. That is the problem really when we start. In a place like Trivandrum, these facilities are not very good. Ours was a hospital basically, so the facilities are even less. So we had to use other institutions for help, which was readily forthcoming. So that once the cage, a prototype is made, we have to do two types of testing. The first is the functioning of the valve. That is, does it open fully? Does it close fully? These are the two essential functions. And also along with that, you have to find out in opening and closing, does it produce a lot of turbulence in the flow? That may damage blood. That we have to check. So the pressures have to be measured upstream and downstream. We have to have photographs of the flows to measure the turbulence. All these kinds of, and this testing equipment, what we call a pulse duplicator, essentially a replica of the heart, left heart model is made. Now that is not commercially available. You have got to design and make it yourself with all these. Now that is what makes this whole pulse duplicator. And also once you make the measurements, the heart rate is fixed at 70, let us say. You want to know, suppose the man is running and the heart rate goes up to 100. Does it function the same way? That has to be checked. So we have to ensure that the rate can be increased. Flow can be, suppose 1/3 ejection and 2/3 relaxation. Now can you change that a little bit and see whether the valve continues to function? All these kinds of testing we can do in the pulse duplicator. Now that is a very crucial test. And then the next test is durability. As I mentioned earlier, the international standards which we follow, ISO, that is international standards, there is a particular number. All valve developers have to follow this. Otherwise, it's not acceptable. And now that insists that it should have a durability of 10 years without any mechanical failure. Now that, as I said, it is 367 million testing. And obviously you cannot do the test for 10 years. So we have to do acceleration. The 10 years are compressed into 1 year. So 70 per minute, we accelerate to 700 per minute. That is how it is done. So an accelerated tester Now that we have to develop, it is not commercially available. So that is again, if there is a problem in the where testing, that model fails, then we have to start again. If that tests for durability are satisfactory, then you have to do animal trials. That's also not easy. Animal has to be sufficiently large, about comparable to the human heart, and we chose sheep for that. From Tamil Nadu, we could get the weighing around 45 kilograms. And their heart, the size, will give a good fit for this valve, our size. Now those animals, they have to be anesthetized. The operation requires the same skill, the same care as you do for humans. And they have to survive 3 months in good condition. Then electively, not because they are sick, this is required, it's a kind of painful thing to do. We have to kill them and take all the organs and examine the heart, how the valve is looking, how the other organs, suppose there are clots coming from that, has it gone and damaged the kidney or liver? All those organs must be autopsied. Tests must be done and shown that this is safe. Only then we can go to the ethics committee or the institute and ask for permission for clinical trials. So this is the sequence in which we have to do this. And as our 82, when we conceptualized this, that first paper, to go through these tests, we had setbacks, mostly in the pulse duplicator testing, wear testing, and animal testing. We had setbacks at each of these stages. And each setback means about 1.5 to 2 years. You have to start again. Generally, in valve development literature, an enormous literature is there. You will find very few people will talk about failures. Only the successes will be reported. Journals don't accept failures. And the authors are not willing to publish either, especially when the valve development is financed by companies. Why do they be secretive? Because if you advertise it, then a potential developer, he knows how to solve that problem. So they will not publish. We had no such commercial motive, so all our failures we published. It is something like Ramanujacharya, when he went to his guru, the guru gave him a mantra, a bija mantra, and told him, this is secret. It should not be divulged to anybody because it leads you to salvation. So Ramanujacharya was not an ordinary disciple. He went up to the Gopuram and he announced from the top, come ye all of you, here is the mantra which will give you salvation. Ours was like that. We had our failures, we advertised it. Quite the opposite of what people generally do. Now these are the 4 models. The model, the picture I showed in the beginning, that's the 4th model which is successful, which has been used from 1990. The model 1, our cage material was titanium, and the disc material was DELRIN 500, made by DuPont. Model 2 was titanium, but the cage initially, that the struts which you saw, they were electron beam welded. In this case, it was an integral cage. We will see this later. And the disc material we changed to sapphire, synthetic sapphire. Model 3, all these models changing because of failures. I'll come to that in a minute. Model 3 was titanium nitride coated, HAYNES 25, that is a chromium cobalt alloy. And sapphire continued. And that failed. So we had model 4, where HAYNES 25 remained. We eliminated the titanium nitride coating, and ultra-high molecular weight polyethylene was the disc material. Now, why did we have to make these changes? That we will show it now. Now, this is the first model. You will see the strut here. If you look at the cage, that's the cage. That strut, it is a bridged strut, not independent struts. That is how the first model was. When we put it in the wear tester, the titanium cage you have seen there, and you can see the polyacetal disc. Polyacetal is a very, very cheap plastic. When this DELRIN, we asked DuPont, we asked for a pro forma invoice for 1 kilogram. They sent us a packet of 10 kilograms free because it was so cheap. I remember that. The first valve, which you see at the top. When we put it in the wear tester, instead of, we are talking about millions, after some 100,000, this is what happened. You can see that major strut simply fractured at the joint where it was welded. It cracked. That was the end of the model. And when this happened, the metal fracture, we had no facility to test it. We didn't know how to deal with it. So we took it to National Aeronautical Laboratory in Bangalore. They did a study for us, and this is one of the pictures they took. You can see the crack very well there. And they told us this happened because in the welding chamber, electron beam welding chamber, there is a trace of oxygen. That led to weld embrittlement. That's why it fractured. And the lesson we got was we should not use welded components in the bloodstream. That's not safe. That was the conclusion. So we had to change the model. So we moved to the next. Now, this is the next model, model 2. Here, the all-integral cage, there is no welding anymore. It's an all-integral cage, and the struts are integral to the cage. There is no welding there. There are 3 independent struts, not British struts. And the disc is suspended in between the struts, opening and closing. That is one very big change. Otherwise, the sewing ring remains the same. And failure mode, when this was tested, the disc is single crystal alumina. We had changed that also because earlier on polyacetal, one difficulty, even though it is very cheap, when you put it in the autoclave, it absorbs a certain amount of water and the dimensional change is there. Even though 24 hours, if you leave it outside room temperature, it comes back to the original dimension, but still it is unacceptable in a clinical application. So we wanted to change the disc also. The disc had come to single crystal alumina, which is very hard, otherwise excellent material. Now, when we tested this in all-integral cage of titanium and single crystal alumina, look at the bottom. Here, you can see the wear of that because this sapphire is tilting against these 2 struts and they are simply wearing. A lot of wear, and the disc actually escapes because the space should be very small, the gap where it is lodged. And if the gap becomes very large, as the struts begin to, then it escapes from there. So this model was not acceptable. So we moved to the third. Now here it is an all-integral cage remains, but we had changed to HAYNES 25. Titanium was not acceptable. Single crystal alumina remained the same. And we also had a titanium nitride coating because that makes it further blood compatible or totally inert, and so that blood cannot damage it. That was an additional protection. Now this failed because the sapphire cracked. You can see that. You can see the sapphire is cracked. So the cage is all right here, but sapphire has cracked. So this method, this also was a failure. Then we moved to the next. That is the current model, the 4th model. Now here the sewing ring remains the same. It's a polyester cloth, warp knitted. There is no change in that. And we have the HAYNES 25 alloy for the housing cage of the valve with no titanium nitride coating. There was no need for it. And the disc is ultra-high molecular weight polyethylene. Now this has not been used in cardiovascular applications. But there is a report of that being used in orthopedics, that we knew. And developing this already, which each setback is something like 2 years. We had already spent almost 6 years when that SAPPHIRE disc cracked, 1988. We had already been spending almost 7 years, I think, by that time. Many people were simply tired. They wanted to give up. Many others were severely critical, wasting money and effort. Indians cannot develop heart valves, that kind of attitude. So we had to work very hard, very fast. That led to some of this testing, for example. We had to make a valve prototype and then do the testing for wear, for example. But we learned the time was very short for us, so we could do sub-assembly testing. For example, wear testing. We could have a pin made of that metal and a disc made of that plastic. We are measuring the wear. So you could have a simple pin on wheel test. So that in a matter of 2 months we get the answer. We don't have to make the valve do this. So we did a lot of innovation that way. So it's possible. 1990 we were ready for all these conditions had been fulfilled, and then we could go for the animal trials. In fabrication, this is the HAYNES 25. It's a very hard material. CNC machining, computer numerically controlled from a solid metallic block. This was done for us by Space Department in Bangalore. None of this could be done in Trivandrum. And the ultra-high molecular weight polyethylene, that was done by us. That's a powder, solid-state compaction in a die with isostatic compression. That was done by our group. But one innovation there, that edge trimming using cryomachining, which is mentioned there, that was something done by our group. In fact, we had an engineer who was a fresh graduate from Calicut Engineering College. He had joined. And one of the problems we were facing at that time, when this disc is put in that 3-piece die, when we take it out at the almost the equatorial type, you will find small micro irregularities, almost like tiny hair-like projections, a few of them. Now that can produce clots. So we wanted to trim that. Now if you take it's a plastic, so you don't get a smooth surface when you trim it. We were not sure how to handle this. That was the time Murali joined. And he came up with a solution that you freeze it, cryomachining. If you freeze it, then what happens, it becomes like a rock. Then you can do the machining, polishing. So that's the only one where we have a US patent. Otherwise, the valve itself, you cannot patent it. But this is patented. That is, and polyester sewing ring remains the same. Now, this is the fabrication of the current valve, which you have seen. And functional evaluation, the simulated testing, it is a heart chamber is being simulated, durability, and animal evaluation. We'll proceed with that. Now here is the pulse duplicator. On the left-hand side, what you see is essentially, you can't see the details of this, but essentially what we do is to simulate the pumping chamber, the left ventricle of the heart. So there is a rigid plastic, transparent plastic case in which a balloon is suspended. And at either end of this plastic chamber, we have 2 valves mounted. And this circuit is completed, and it is primed with the water solution. And as this balloon inflates, then the valve is pushed open, and the outflow valve through the fluid comes out. And when the balloon is deflated, that is the relaxation phase, the fluid comes into the chamber. So this is how it is done, and pressures are measured upstream and downstream, and flows can be photographed and recorded. So this is the rate can be changed as we like. Suppose from 70 to 100, if you increase it, is the flow normal? Are the pressures remaining acceptable? All those can be measured. That is on the, that chamber is shown on the This is where the heart chamber and related equipment. On this side, we have the controls and recording and all that. So this is the pulse duplicator, which is built by us. It's not commercially available. And there we got considerable data. And some of these changes which we had to make, model 1, 2, etc., some of these are also due to the data from which we got from the pulse duplicator. Now here is a wear tester, and here again there is a rigid chamber in which 5 valves are mounted, and the rate is increased to 700 times from 70, so that in 1 year we get the results of 10 years durability. And at every 30 million it is taken out, the disc is taken out, and the weight is measured, the volume loss is calculated and all that. That is how the wear testing is done. We have published all these also. Now the wear of the metals and plastic must be tested for 10 years, 36 million which I mentioned. And the trick to do is to accelerate the testing. 70 we make it 10 times. And that is necessary to get the International Standards Organization. We have published all these in a great detail. Now this is the animal evaluation. These are magnificent animals. We used to get them from Coimbatore. They tolerate the operative procedure very well. The next day they stand up. You can see the bandage. The bandage is still there. There you can see the bandage. So the next day they stand up, which patients cannot do. And mitral valve was the one which is very frequently diseased in human beings. So that's the valve which we replaced. In 3 to 6 months, they have to survive in good health. Then only we are allowed to do autopsies and take out organs and do the testing. And we have to have a minimum of 3. We had actually 5 animals we had done. And this requires not only the surgeon with the anesthetist. Anesthetist, we had to have very skilled people to give anesthesia to the sheep during operation. Now this is an autopsy taken from an animal at 3 months. And you can see how that valve has healed very well. There are no clots there. The valve is sitting very clean. No destruction of any tissue, no clot formation, no infection. So this is exactly the kind of result which we expect, which we must have. Otherwise you cannot proceed beyond. Now this was a clinical evaluation, but we have come to a stage when clinical evaluation. So we need to have the ethics committee approval. And ethics committee, as you know, it is an essential requirement. In those days, it was not very common in India to have, because there are very few implants development activities. So now they are well established institutional ethics committees. They simply didn't exist at that time. We were one of the pioneers in that. In fact, when we approached the Kerala High Court Chief Justice at that time, Justice Poti, I didn't know what the legal position was. He didn't know either. He said, I don't know about this. I knew the international situation, how ethics committees evolved, very big issue abroad. So I had all the literature, and then he asked me to discuss it with Justice Sukumaran, who was interested in social issues. So I had a long discussion with him. He was so much interested, he said, I'll be your chairman. So he was the chairman of our ethics committee. We had a professional expert, surgeon, Dr. Demis Shah, a very senior cardiac surgeon from Bombay. So there is a certain way, according to international standards, to set up the committee. There must be a lady, etc., etc. A judicial person should be the chairman. So we set up a committee, and that committee looked at all the data. They can ask us to delay. All that they can do, and we are obliged to follow that. So that committee gave the approval in October 1990. We had that concept paper we published was in 1982. Already 8 years had passed. And we started this, the first valve was done on 6th of December 1990. The committee had given us approval for 40 valves to be done in our institute where it was developed, and one surgeon, that is me, I should do these cases. So the responsibility is mine. So this was done without any mortality. Results were very good. Then the committee met again and they said, now you can do multicentric trial, which is essential. These are all international standards. You have to do minimum 3, optimally 5 institutions. These are very difficult to get agreement from surgeons who are willing to do this test. They should have confidence, they should have willingness to do it. You cannot give incentives, you cannot give cash, that is not permitted. So we had very good fortune of getting the support of Armed Forces Hospital in Pune, the GKNM private hospital in Coimbatore, JIPMER in Pondicherry, KEM Hospital Bombay, SSKM Hospital Calcutta, and our own institute in Trivandrum. These were the institutes agreed to cooperate in this multicentric trial. That's where it started after our clinical trial was successful in Chitra Institute. Now this is the first valve implantation done on 6th of December in our institute. And on the left-hand side you see the actual picture, the surgery being done. And you will also see at the bottom on the floor, the heart-lung machine, and you see 2 devices, one here, another here. Now that upper device is a receptacle. The heart-lung machine, what it does is taking the venous blood from the patient through a tube. It comes to the heart-lung machine, and the heart-lung machine is a bubble oxygenator. And that bottom one is the bubble oxygenator. And the top, the box which you see there, that is the blood which is sucked out during operation. That also has to be filtered and added to the circuit so that the blood, venous blood from the patient comes to this oxygenator. It is oxygenated and returned to pumped back into the patient. That is how heart-lung machine works, because the patient's own heart and lungs have been stopped. Then only we can operate. So during that time, these functions are taken over by these 2 devices. And now they are magnified in this picture. You can see this is the cardiotomy reservoir, blood sucked out from the heart comes into that. And this bottom one is the oxygenator, which does the function of the lung. Now these 2 devices were also developed by our Chitra Institute. So in this particular operation, it is unique, not only the heart valve, but also these accessories, oxygenator and cardiotomy reservoir, they were also developed by our group. Now, I have mentioned here and there, in Chitra Institute alone, that was the lead institute, but they alone could not develop this, obviously. So when we had a strut failure in the early days, we had to go to NAL Bangalore. And they were the people who told us why the fracture happened, how that could be prevented. That's crucial information. We depended on NAL Bangalore. Then it came to the polyester fabric. Polyester is well known. Even make clothes are made of polyester. So we approached Coimbatore Textile Research Institute, CITRA. They knew everything about polyester, knitting, different types of knitting, warp knitting. They knew all that. But they had never heard of in heart surgery that being used. They were curious, surprised, and very happy that they could be helpful. And they made that sewing ring for us, because that has to be fitted into the valve, very much like a tire is fitted on the wheel for a car. That's how it is fixed. And they did a first-rate job. Through all these model 1 to 4, We had to change almost everything else, but sewing ring never had to change. That was done by Chitra for us. And then came to computerized numerically CNC machine and this EDM, electric discharge machining. That is integral cage construction. That was done by HAL Bangalore for us. They had done the electron beam welding, which failed. So this CNC and EDM, they were done by HAL for us. Then came a stage we had to make some 300 valves for multicentric trials. We have to distribute these valves to these hospitals. Now that is a kind of pilot production. You can't expect HAL to do pilot production. So the GTTC Bangalore, government tool room, they came forward, no problem. All the machining is done by them, but the polishing, that is a medical level polishing, that is almost like a mirror, that kind of polishing was done by us in Chitra Institute. Then the very critical, the third model when that failed in the sapphire disc cracking in that sheep. That was one of the biggest crises we faced in 1988. We had to find a solution quickly because already so many years have passed. How do you quickly do this? What are the likely plastics we could use, unbreakable? That time a list of 3-4 plastics, including ultra-high molecular weight polyethylene, these were suggested by NCL Pune. They didn't make anything, but they suggested these are the ones we were likely to find. That was very valuable information for us. And we do these quick tests, accelerated testing, not accelerated testing, but component testing. So we could speed up in a year and a half. We were ready with model. So you can see, even though there is a nodal institution here, but the inputs came from all over the country. So it is a networking which tremendously increases the power of our group. Now this is the paper that we published in 2001 in the International Journal. There is a Journal of Heart Valve Disease. Any major development has to be published in that for the world to take notice. So this was published in 2001, our results from all the institutes. That was a landmark for us. Now these are, I'm just showing, when you have a valve implanted, the international standards again require certain types of follow-up is necessary. You must indicate the late mortality. Are there any clot formation, thrombosis? Are there any bits of clot being released, embolism, hurting the patient? Any infection? All these must be reported. There are a few more. So otherwise it is incomplete. So we have taken the 2 CHV is our valve, and what is shown here, Antunes, that is a similar valve, Medtronic Hall valve, very similar to our valve, tilting disc. But that was, it is not, if you want to compare post-operative follow-up, you have to compare with a similar valve and a similar population. If you take an American series, for example, the average age of the patient is 50 years. So that is not comparable. Or the valve model may be different. So here we have from South Africa, Antunes was operating in South Africa. Patients are similar. And the valve is also similar. So we have, and you will find in all these parameters that we have measured, ours is slightly better. Freedom from thrombosis at the end of 5 years. Freedom from all valve-related mortality, like 76, 75. These are very total survival at 5 years. That is a projection actually. But in all these, the Chitra valve has done very well compared to international model. Now this technology was transferred in 1995 to TTK, and more than 1.5 lakhs. Now it has reached 1.6 implanted till date. And about 230 centers in India are using this valve and is exported to developing countries. That is the current status. And the National Technology Award was given jointly to our institute and TTK Healthcare. Now the update, this 2022, the first patient who received the Chitra valve is alive and well. He was a teacher at that time. Now he lives in Thrissur and implanted 1.6 lakhs. There is no case of mechanical failure reported in any of these valves so far. Now this is a picture of the team. From the left, one is Krishna Manohara, who was my student, who assisted me. He's a very prominent cardiac surgeon now in Haryana. He's a specialist in pediatric cardiac surgery. He's standing there. Then it is me, and next is our patient, Muralidharan, who on the 6th of December 1990 is still alive, is active. So he is there. And the next is Bhuvaneshwar, the engineer who was my student in IIT, later on came and joined. Now he's retired. He's a first-rate engineer. Next is Janet, our theater nurse. Next is Rathod, who was our anesthetist. And Thomas, who ran the heart-lung machine for us. So that is the group in this. Now there are certain things I would like to stress here. One is, as I mentioned already, networking is extremely important. Without that, if we insisted that we had to have all these facilities made available to us in Trivandrum, nothing could be done. We cannot have all these facilities, but all these are available. We approach, and there is a lot of goodwill. If it is not commercial, suppose we are doing something like this scientifically interesting, challenging, and it is useful for patients, you will find a lot of good people supporting, going out of the way to help. I have given all the list. So that networking, the importance is often underestimated in India. That is essential. And another point I wish to make is, in this development, Bhuvaneshwar, for example, the other two engineers who, that edge streaming technique, cryomachining, that Murali, Ramani, there were three engineers. All these three engineers received their engineering education in India. One was in the IIT, other in the state engineering colleges. They had never gone abroad. No foreign help was available for any of this. We never consulted anyone. No help was sought or received. The entire thing was done by our own people trained in this country, young people. First jobs, actually. Bhuvaneshwar was the first job after his degree from IIT Madras. And Murali, after his engineering qualification from Calicut, that was his first job. There is another technology which we developed along with this, along the same time. That was a blood bag, which is used extensively in blood transfusion. You cannot have blood transfusion service without blood bags, because that enables you to separate the components. Now that we developed at the same time. Now today, that blood bag technology, blood bags are made 60 million in India by two factories in Trivandrum. That meets 50% of the Indian market and exported to 80 countries. Now this was developed by, again, an Indian engineer, S.N. Paul, who got his degree from UDCT, Bombay. This was the first job for him. So we have all these examples, the tremendous potential that we have in this country. These were very happy lessons for us, which would have made Sir C.V. Raman very happy, I know. So I'd like to stop here and thank you for this great privilege of giving a lecture in the Science Week.
Yeah, thank you very much, Professor Valiathan, for very, very inspiring lecture. I'm sure all the participants you try to learn maximally from your lecture. So, if you have questions, please send an email to our office. So we will collect them and send to Professor Valiathan. So, okay, so I think we can send our appreciation through this recording. So let us thank the lecturer again. So next. Yeah, so next Monday is Science Day, the last day for this Science Week celebration this year. So I will be giving a lecture from 3:30, and Professor Ajit Kembabi will be giving the lecture from 5. So please do come. So we will be talking about black hole, different aspects of black hole. Okay, thank you.